Judith, you pointed out in your review that there was little evidence that primary care-led commissioning was effective in challenging hospitals, although they were effective in improving primary and intermediate care. If clinical commissioning groups are to influence care in hospitals, what do they need to do differently?
I think what they need to do differently is to move beyond the idea that there's some very deep purchase or split between purchasers and providers that somehow they're trying to transcend. So this time it's not about GPs trying to get hospitals to do things differently. It's about how GPs and hospital consultants are going to actually work together to develop new forms of care, particularly for older people or people living with chronic conditions. So I think what we might see increasingly is GPs together with hospital specialists, perhaps taking on a budget together, committing to run and improve those services in a different way. Now that's not necessarily how clinical commissioning is always being presented and described at the moment, but I think it's going to have to work like that if this time it's going to be different, because I think we've made lots of the improvements in primary care to date. Hospitals again have changed how they work, but we need a whole step change now in terms of, I say, care for older people and urgent care and some of those really knotty problems that need to be solved.
Sounds quite exciting. Judith, is there any evidence that GPs, because they have that close connection with their patients, will be better able to pick up and address the issue of safety and quality and patient experience?
Yeah, yes, we do have evidence from past experience, particularly, for example, the total purchasing projects that we had in the late 1990s, where general practitioners experimented with, some of them did, with taking on a whole budget for their population. We saw there that GPs, and when they're well supported by high quality managers, they can bring about some quite significant changes in how care's delivered, both where it's delivered and how it's delivered, and can monitor the quality of that care in a quite forensic way. However, the caution there is that that experience was shown to be relatively sporadic. It was only some were able to do that, but also, very critically, they often found it hard to move the resource to sustain that change in the long term. It's often relatively straightforward to do that for like projects or sort of initiatives, but to really make that mainstream is much more difficult.
And of course we do have the example of Mid Staffordshire, where GPs heard some of the complaints of their patients, but they didn't actually pull that information and do anything about it. Judith, we've now have a situation where clinical commissioning groups will be held to account for an outcomes framework. Is that going to be different to the situation we had with primary care trusts?
I think it has to be to justify another iteration of commissioning. Now we're 20 years into working with commissioning, and when we have an evidence base that's relatively equivocal as to how successful commissioning has been in assuring high quality services. So what I think is really important this time is that we're careful not to overload clinical commissioning groups with too many responsibilities, too many tasks, where they just become bogged down and overwhelmed potentially by it all. And I think where there's real potential is for them to be, in a sense, the stewards or guardians of the NHS outcomes framework for their local population. So to be committing to perhaps a relatively small number of either targets or standards that are deemed to be particularly important for that population and the sort of care and the health outcomes that are required, and for the clinical commissioning group to commit to how it wants to actually improve services to meet those standards. So perhaps to be upfront with the local population about both where services are performing well at the moment, where they're not performing so well, what it's intending to commission to change that, and to be prepared to account to local people as to how it's doing in terms of making that progress. Because I think that in that way, the local GPs, say, taking ownership of that new approach, and I say being stewards, and I use the word very thoughtfully there. So, because I think then it could be something really quite different this time. And GPs do have the trust of local people usually, and I think that's important.
So the focus is going to be key.
The focus is key, but if they're, again, another NHS management organisation that spends its time looking upwards to be told what to do by the centre and get distracted perhaps sometimes by national priorities, which may be legitimate, but if that prevents them understanding what's going on locally and being able to account for that to local people, we won't make the progress we need to.
Judith, you mentioned it's important to get cooperation between GPs and specialist doctors in hospital. What benefits do you think that will bring? But are there any downsides that collaborative arrangements could engender?
Well, one person's collaboration can be another person's collusion. And there's a risk that general practitioners working with hospital specialists, potentially could be working together to protect local services. Now, whilst those local services might sometimes need protecting, on the other hand, they might be protecting services that aren't of the highest quality or that actually need to change. And of course, that's why we have commissioning as a potential challenge to either poor or outdated practice, or indeed to make sure that the services that are put in place are right for a local population. So, as well as having clinical commissioners who work closely with specialists, we do still need a very robust accountability framework that both the Department of Health, that politicians, that local people can hold those commissioners to account against.
Yes. You need other checks and balances
in
the system.
It's a complex, large, publicly funded system with over 1 million people working in it, so it's going to need very careful both funding but accountability arrangements.
Judith, thank you very much for sharing the lessons of history. We've got a lot to build on, I think, from the paper that you've produced. Thank you.
Thank you.